Right. Welcome, everyone. And it's fantastic to see many faces we recognize joining already. This is a webinar. We're kind of using the LTCcovid webinar slot and facilities, but this is very much about England. And we will be announcing a new series of LTCcovid webinars starting around mid-June. But for now, we're very delighted that you have all joined us today. We're going to be talking about the project called Social Care COVID Recovery and Resilience. And it's looking at what lessons England can learn from other countries to become, for the social care sector to become more resilient. So I'm going to start very briefly, just I think I will come in. Just remember that this webinar is being recorded. So I'm going to formally start this webinar now. So as I said, this is a project called Social Care COVID Recovery and Resilience, lesson learning from international responses to the COVID-19 pandemic in long-term care systems. This is a project that started in January 2021 and ends in June 2022. This is a project funded by the National Institute for Health Research in the UK. And any views you will hear today are from those of the member of the team and not from the NIHR or the Department of Health and Social Care, the LSE or the Nuffield Trust. And we've listed all the members of the team. As you can see, there's many of us here, some very part-time, but it's great to have this fantastic team behind this project. The aims of our project are to draw lessons for policy and practice from international COVID-19 experience and from the scientific evidence so that this can support how the English social care sector can recover from COVID in the short term, is better able to withstand future waves of COVID-19 and similar shocks in the medium term, and to become more resilient in the long term. So we are covering a lot of aims. And it's very important that we clarify what we mean by the social care sector. Although we're using the word sector, we are including in this all the people and institutions involved in using, providing, organizing, and funding adult social care. And we include both paid and unpaid care, care in people's own homes, in the communities, and in residential settings. And we're also including both public and self-funded care and adults of all ages, so younger adults and older people. This project, it works in phases. At the moment, we're in the blue phase on the left of this slide. So we started by analyzing the situation in England and developing a theory of change map, and today's presentation will cover some of that. This is going to help us identify priority topics in areas where evidence is needed, but this is also informed by a mapping of the scientific evidence, so we know what's there, and also by gathering accounts of international experiences. This will help us then with choosing some topics and countries where we're going to be looking in more depth in the second part in the project. We will be conducting literature reviews on the key topics identified, and also will be conducting 4 case studies in 4 countries from where we think that we can learn relevant lessons. And at the end of the project, we're going to revisit the theory of change to develop jointly with stakeholders policy and practice recommendations that are relevant to the social care sector in England. And I'd like to emphasize here how much this project is trying to make sure we understand what is going to be relevant and what is going to be helpful. So I'm going to now hand over to my colleagues. I think Camille Oung is going to speak from the Nuffield Trust on the first part of the project, which is a situational analysis of how COVID-19 has affected the social care sector in England. Camille?
Thanks, Adelina, and it's nice to see everybody on the call. So yes, as Adelina says, I'm going to talk through the situational analysis. So the Nuffield Trust have mostly been leading on this strand of the work. And the overarching purpose of this workstream was to get an understanding of the English social care response during the pandemic and make sure that we have a good understanding of the context with which we would relate our findings from the other workstreams. Adelina, if you could move on to the next slide. Thank you. So we have three kind of sub-aims. Firstly, we wanted to examine some key lines of inquiry. So we wanted to see the impact of COVID across the sector for those providing and drawing on care. We wanted to see where there were weaknesses in the pandemic response and why. We wanted to see which parts of the response were also particularly effective, where there was good practice, and also some of the learning that took place iteratively between the waves and how prepared the system was. Secondly, we wanted to get an understanding from stakeholders of the priorities for the short, so let's say in the next 9 months, medium, so over the next year to 2 years maybe, and then long term for the sector. And so our ambition is to draw on these priorities to help select the international case studies. And then we also wanted to ensure that our findings are timely and feeding into policy decisions where relevant. If you could move on. Thank you. So there have been a few components to the work. So we started off by quite an extensive stakeholder mapping exercise, and the ambition was to identify as many relevant stakeholders as possible and ensure that a multiplicity of perspectives were captured in the work. So we followed some of the STRIDE guidance on stakeholder mapping, and we identified over 130 individuals, so from the expertise of our project team and from our advisors as well. And we used this stakeholder exercise to select the theory of change participants, which you will see later. And we also identified 15 interviewees and members for our advisory group. So following the stakeholder mapping, we undertook a document review of publicly available documents, and that was including government guidance and policy papers, and we chose documents that were published between November 2020 and March 2021. So we chose that time frame because we built on an existing paper, which you can find on the LTCcovid website. And so we influenced kind of the documents that we chose from the stakeholder mapping that we've done to ensure that we were covering a good range of perspectives. And then over the last few months, we've been conducting 15 interviews with a few still to go across a number of key representatives of the social care system to harness learning and identify the priorities. And as we'll come to later, the theory of change was done over 2 sessions, and we'll go into more detail shortly. We're analysing all of that evidence thematically using a coding framework from which we developed from the existing literature, and we're refining as we're going along, and this is informing a number of our outputs. So hopefully shortly we'll be publishing a briefing in the next few months on the lessons learnt from COVID in England, as well as an England response document, and also to support the international case studies. And as I said, we want our findings to be timely. So where relevant issues or consultations have come up, we've used these as opportunities to synthesize our learning. So some of you will be aware of the mandatory vaccinations consultation, which closed last Friday. And we fed some of our learning from our situational analysis work and supplemented it with some international input from the LTCcovid contributors. Thank you. So we just wanted to touch on some of our emerging findings, and I want to stress that these are still emerging, but there were 3 kind of buckets of factors which determined the impact of COVID on the sector in England. So firstly, the structural faults which have been well embedded prior to the pandemic, the response itself, and that especially in the early months, and the level to which the system was prepared for an event such as COVID. So if you could move on, Adelina, I'll start with the underlying structural challenges which shaped and limited the nature and extent of the response. So the interviewees that we spoke to highlighted to us that the crisis in social care was precipitated by some of these kind of structural faults. So the long-term underfunding of the sector, a fragile provider market that had limited opportunities to invest in care that people want and need, severe workforce shortages with sometimes difficult working conditions, low pay, limited opportunities for training and career progression, and also a paucity of good quality data which would help with planning and understanding what is happening on the ground. So the next set of challenges, if you could move on, Adelina. Thank you. That we highlighted were in the COVID response. And so the interviewees that we spoke to and the documents that we reviewed stated that relative to the NHS, the COVID response for social care was hampered by a number of factors. So things like low visibility of the fragility and complexity of the sector among key decision makers. There was a lack of coordination regarding PPE and testing, especially in the early months of the pandemic. and some complex mechanisms for accountability and communication, and that's been largely made more difficult because of the complexity of the sector. And then finally, moving on to the preparedness point, I think there's some well-established evidence. So, you know, the NAO report, for example, around the preparedness for the pandemic and potentially some missed opportunities in the early months. But we think, you know, from what our interviews have said, it's also important to recognise the rapidly evolving situation which no one had dealt with before. And something that did come out from our interviews is that there's been a lot of learning, especially in preparation for the new waves of pandemic. So things such as the social care task force, which has guided some of the later response, some sharing of good practice, and our respondents were really keen to see some of that continued and embedded as the sector recovers and hopefully builds back more resiliently from COVID. So I'll hand over to Max now, who will be talking through some of the scientific evidence.
Thanks, Camille. Yeah, so in this second part of the project, we're looking at what we can learn from the scientific evidence or from international studies, but also studies from the UK. Next slide, please, Adelina. And the way we're doing this is really through a phased approach. So Adelina already mentioned that we wanted to first map out the evidence. So we wanted to understand what types of interventions and measures have been studied in social care settings during the pandemic. And I will be talking about the findings of this mapping review in a moment, just to say that this has also been published as a preprint on LTCcovid.org, so you can look at the report there. We wanted to use this mapping review as a basis for informing a range of targeted scoping reviews where we want to zoom in on individual interventions or other topics. And we wanted to conduct these reviews as scoping reviews, focusing not only on the effectiveness of possible interventions, but also to understand better what type of evidence exists. For example, we now know that ventilation is coming up as a hot topic potentially, and so it would be good to understand what types of studies have been conducted in social care to look at this. And then along the way, we have been publishing and will continue to do that evidence summaries of either individual articles or of newly emerging bodies of literature on specific topics. So the most recent of those is a brief summary of the available studies looking at the effectiveness of COVID-19 vaccines in nursing home residents, and that should be coming out soon in JAMDA. And then other evidence summaries have been published on LTCcovid. One is looking at how information and communications technology have been used during the pandemic. And then others looking at other aspects of vaccination, including the protective effect, but also some reports of outbreaks happening in care homes after a lot of people have been vaccinated already relatively briefly after the start of vaccination drives. Next slide, please. So for this mapping review, we wanted to look at what types of interventions have been studied in social care in the first year of the pandemic, so throughout 2020. So again, really the aim here was to map the literature, not to exhaustively document it and review it, but still we were able to draw on quite a broad range of database searches. And we used very broad inclusion criteria. Essentially, we wanted to document and include any study that has original data about some form of intervention or measure or something that could be done in long-term care settings, including in home-based care. Next slide, please. And what we found is, we found 137 published studies conducted in 22 countries throughout 2020. Most of these studies were concentrated in high-income countries and in particular in the US, some studies from the UK as well. And there was this heavy emphasis on institutional care. So almost all of the included studies were looking at institutional long-term care settings, nursing homes. Only very few were looking at home-based care or community-based care. And potentially reflecting the rapidly evolving nature of the pandemic, all of these studies were observational, and really the majority of them were descriptive. So they were often case reports or case studies of how individual nursing homes or care organizations responded to the pandemic and what they were doing. So I'm mentioning this because we are somewhat limited in what we can say about how effective individual measures have been because of the nature of the evidence. Next slide, please. So what we found is that there were a few main types of interventions that have been studied. Firstly, this large group of measures to prevent or control COVID-19 infections. And really that consisted of a lot of documentations of how nursing homes have responded to outbreaks. And what was common to them is that they all were multifaceted outbreak responses, various approaches to testing, cohorting and isolation, how visitors were dealt with, etc. But again, just to highlight that it is difficult to know what the individual contributions of each of those different components was to actually preventing and controlling transmissions and severe outcomes. A second large body of evidence was on possible targets for future policies and interventions. So really looking at characteristics of nursing homes again, that might be amenable to change in the future. In particular, ownership, so private versus public ownership really, or for-profit, not-for-profit. What is the quality of the nursing home? And then various staffing arrangements. And the findings here are somewhat mixed, but there is a body of evidence emerging on these types of characteristics. And then there were also a number of studies looking at how we can treat COVID in people who need social care and also maintain their access to other regular healthcare. And for that, telemedicine was often mentioned as a way to do that. Next slide, please. And telemedicine, but also other ways of using information and communications technology came up as a theme that sort of cut across all of these different intervention types. So yeah, telemedicine, but also other means of or communication really was used to maintain access to care, but also to keep people connected to the outside world, to their families. And then finally, we found evidence gaps for a number of areas. I already mentioned that there were only very few studies looking at home-based care and community-based care. There wasn't really anything on more structured psychological interventions to combat the psychosocial impacts of pandemic or of isolation really. Very little on environment or how buildings, how institutional care is provided. And relatively little on unpaid care, although Klara, I think, will say more about that. And then evidence on vaccinations is really only picking up now in 2021. So in our report on this mapping review, which was focusing on 2020, we haven't included any studies on vaccinations. So I'm handing over to Klara to talk about unpaid care.
Thank you, Max. And actually that's given me a really nice introduction with some of the themes that you've brought out, because they also emerged in a paper that I'm briefly going to show you the kind of key results of. And that paper is very much linked to this project, but actually precedes the project. But we thought, given the relevance of the results, it'd be useful to showcase this as it focuses specifically on unpaid carers of adults. So we did a rapid review of the academic and grey literature between July and November 2020, and we found 40 studies from 10 different countries. And there were a number of topics that we identified as kind of crucial. And one of those is care commitment, which basically showed that a lot of people have taken up unpaid care responsibility during the pandemic, but also for many people, the amount of time that they spend caring has increased. Carers experienced a number of concerns related to COVID around getting a COVID-19 infection. What would then happen to the person they care for? What would happen if the person that they care for needs to be hospitalized? Difficulties in adhering to restrictions, to just name a few. Then another key topic was around the availability, and that was mostly around availability of services. So specifically services in the community, whether that's home care or sort of daycare that were services that were suspended or reduced, or where actually families decided that they didn't want to continue the services because there was risks or concerns around infections. Then some carers experienced financial implications. as it became more difficult to combine work and care for those who worked, but also for others, there was a number of different financial implications that we identify in the paper. Then there were aspects around carers' health and well-being, which sort of ranged from carers' access to health services, but also the implications of caring. While some carers said actually it was very nice that they had more time because they could work from home or could spend more time at home, they could spend more time with the person they cared for. Others, there was evidence that that had negative implications on carers' physical and mental health and well-being, social isolation and loneliness. Another thing that we found, which probably is not surprising for people working with unpaid carers or who are unpaid carers, is that adaptability, that actually a lot of carers adapted to the challenges of the COVID-19 pandemic and found ways that they could kind of make the resources that they had available themselves work for them. And then we also looked at carers of people who live in residential care settings, and a lot of the evidence around that was around the frustration of not being able to actually see the person sort of feeling guilty and stressed, but also being worried about and being unable to monitor the care and the well-being of the person that they care for. And in terms of measures that were addressed, that were put in place to address the impact on carers, that very much links to what Max has presented earlier, that aspect of technology that was often used, which was largely welcome, but also it was made very clear that actually that doesn't replace in-person support, but also financial assistance and support for working carers, where it's clear that in systems where carers have some more of a social safety net system and the sort of safety net that they can fall on, actually the implications seem to have been less severe than in systems where this wasn't the case. But this is just in a nutshell what we found in the paper. Thanks, Adelina.
Thank you very much, Klara. And so now it's me again. And just going to introduce a little bit the work we've been doing in sifting to the increasingly huge amount of information there is on the experiences of different countries, and of course the LTCcovid platform and all the contributions that researchers all over the world have made has facilitated that. And what we are trying here is to identify potential for learning. So what we've done is we've been looking and started to write up a kind of live report that we hope to be able to share fairly soon as a searchable database, where we'll be able to look at the impact of COVID on people who use unpaid long-term care in different countries. We'll also have a brief description of the key relevant long-term care system features, and we hope that this will be also a helpful thing to have in the long term. We'll be reviewing the measures that have been adopted and the barriers and facilitators to the COVID-19 response in the long-term care system, and thinking about the lessons learned. And as I said, in this project, we're very much looking at identifying potential for lesson learning. We're trying to do this systematically using framework analysis, and we're about to actually start that. But I'm just going to give you a flavor of the type of experiences that we identified rapidly as examples where we thought it was interesting to learn from. And so for example, in Australia, there seem to be very well organized rapid response teams ready to support care homes that had outbreaks to prevent staff shortages and reinforce them. But of course, then we also saw that in practice, perhaps that wasn't sufficient to support the affected care homes, and we think that that's a potential an area that would be potentially interested to learn more about. We saw that in Denmark, all nursing homes have private rooms with their own personal space, including kitchenettes, and that this may have made the isolation within care homes a lot easier. And also the fact that couples that are unable to live together in care homes may also have made some of the big personal costs experienced by visiting restrictions less of an issue, because couples already live together many couples already live together in care homes. And we thought that it was very interesting to see how different the approach to the type of care homes was in these different countries. Also in Denmark, COVID-19 from the beginning was regarded as a work-related injury, and that meant that workers were already entitled to compensation, which may have created a situation where they didn't have to choose between having a wage and potentially passing on the infection, as we've observed in other countries. In Israel, we thought it was very interesting to see how their coordinated and robust emergency response that also enabled high-speed vaccination of care homes. Japan already had very well-established infection control protocols in care homes. And in fact, when the pandemic started, they were already isolating care home residents with flu. And that may have meant that it was easier for them to keep COVID out of care homes, because they were already in this very high alert during the initial flu season that coincided with the initial flu outbreak, COVID outbreaks. In the Netherlands, we were very interested in how client councils in all care homes have a right to make decisions about their daily lives. And these included making decisions about visiting restrictions from the second wave onwards. And we think it's very interesting to understand better even how this has worked and whether this has made a difference to these difficult choices that have had to be made in care homes in relation to visiting. And in South Korea, we also were interested to see how efficiently and rapidly mass testing in care homes was deployed whenever there were local outbreaks, and their policies of moving residents to care home to hospitals to avoid within home spread. This seems to have worked very well, but there may also be other implications on the welfare of these people that may be interesting to understand better. So this is just to give you a flavor of the type of questions that we could be asking of other countries. We are in the process of trying to do this more systematically, to come up with a list of countries and topics that we want to look at, and that will then help us choose 4 countries and also a set of questions that we will be asking of those countries. So now I'm going to move to introduce a theory of change, and also how we have used it in this project to map a path towards recovery and resilience. And I'd like to credit Erika Brewer, who works as a consultant, has facilitated this work, and also I have to confess that some of the slides are actually hers, and I'm just very grateful that she's letting us use them. So what is theory of change? Well, let me say first, it's not a theory. It was originally developed as a monitoring and evaluation approach with the idea of responding to what was seen as a black box evaluation of programs. And it was seeking to understand how and why a program brings about change. And here what we're taking in this project is this essence of how and why something brings about change. And we want to see how our project can contribute to bringing this change in the social care sector in England. So just to illustrate a bit more, so say we have a treasure map, and we know that we are here. You see, we're in this ship that is arriving at this island somewhere, and we want to go to the X. That's where the treasure is. That's where we want to get to. And what theory of change is doing is helping us map how we're going to get there, and it's helping us trace the path to get to where we want to get to. And of course, very important to have an understanding of where we are, and this is also what we have been doing through the situational analysis. And I'd like to emphasize as well that one of the great beauties of this theory of change process is that the wider the range of expertise and experiences that you bring in, the better you'll be able to understand these tricky bits of the path that require people who have knowledge of all the different parts that need to be in place. And I really like this slide that I borrowed from Erika, and I'm not sure where she got it from. It's got a signature by a very talented person. But saying, I think you should be more explicit here in step 2, which is then a miracle occurs. And quite often this happens in a project. We know where we'd like to get to. We know where we're at the beginning, or hopefully we do, but we're not very sure what needs to happen in between. And here we've been using theory of change to try to unpick this bit in the middle. And we've been very grateful to a lot of people who've given up a lot of time to help us map this. And we're hoping that perhaps through this webinar, you can also help us a bit. So theory of change, the formal definition is that it's an outcomes-based approach which describes how a program brings about specific outcomes through a logical sequence of intermediate outcomes. Now, this is a bit of a mouthful, and it's got the word outcomes in it many times, but this is usually a collaborative process and ideally done through a workshop with stakeholders. And how is it used and when? Well, it was originally developed to look at research evaluation, but we're increasingly finding different kinds of users. And here, and in a project that some of us worked on before called Stride, we've been using it for strategic direction, to map a path towards strategic direction. But it's also been used for reporting accountability, for intervention development, and to provide, as I said, a framework for research and evaluation. Usually you do this in person in a workshop over ideally 2 different days. And these are some examples of where we've used theory of change in live settings. And you can see it's a very involved collaborative approach. It involves a lot of big post-its that you put on the wall and you together build a map and create it. But of course, in COVID times, as you can see, this doesn't really comply with physical distancing measures, so it wasn't possible to do it like this. So for the social care R&R project, we did it online, and we did it over 2 mornings, so not 2 full days, but just 2 mornings during 2 weeks. In the first workshop, we looked at the challenges that are in place for us to achieve the impact of the sector recovering and becoming more resilient. We agreed on the wording of the impact, and it's a bit different than what our original project set out to do, and that's something we will take forward. And we're very grateful for this contribution from the participants. We then developed an outcome map, and I will explain that a little bit more. And the second week, we reviewed what had been happening. We also had, in the meantime, organized a little bit all the stickers that had appeared. And we worked together to develop strategies that would help us achieve the outcomes. And finally, we did think a little bit about what would be the indicators that would tell us whether we've achieved this place where we want to be. And this may not seem very clear to you at the moment, but hopefully seeing an example will help. Just for the technical side, we used something called Mural, and this was done through an online workshop. And we thought that to give you a clear indicator, a bit more of a more lively idea of how this works, we thought that you'd like to hear from our colleague, Margaret Ogden, who's a member of the Public Involvement and Engagement Group, who's going to share her experience of taking part in the Theory of Change workshop. So, Margaret, the floor is yours.
Adelina. Pleased to meet everybody today. I'm quite new to London School of Economics and also Kent, and my background is in health and public health, but I just knew I had to get involved in social care to see the whole picture. I was carer of my 90-year-old uncle, and he's now in a care home. Also, due to isolation during COVID, I needed social prescribing myself, so I had that experience and it was really helpful. So that's my background. I was thrilled to attend the 2 workshops, and developing the mural for me was such an exciting event. I'd never done anything like that before. I knew I probably was going to be challenged with the software, and Klara kindly offered for me to be buddied up with Stephanie, and that got me through it very nicely and meant that I could concentrate on the content of the workshops as opposed to having to focus on the technology. So we kind of buddied up and used the chat function, and that worked really well, except on one occasion we ended up in 2 different breakouts, but we soon got over that, and it was a great experience. I thought it was excellent engagement with such a diverse group of stakeholders, and we were there as service users too. There were 3 of us. I hadn't really met them before, but we've bonded very well in moving forward. It was a step-by-step approach, and it was really interesting how the whole thing evolved over the 2 days. The developing the map, that was something that evolved, and it was quite amazing to see how it started as a small thing and it developed into something very big. It was an opportunity to consider the macro issues. So I could see there were a lot of big issues appearing on the mural. And I was perhaps going to need a little bit more help on those big issues. But it was a great way to move this along and how to get to a really good position. And my impressions of it, I just thought it was a fantastic day, and the organizer, Erica, she was really dynamic, and she had this lovely way of including everybody. Even us service users that, you know, for me, for one, there were times when I did feel a little bit out of depth, but Erica just had this way of making everybody feel comfortable, and it moved along very quickly. So the big impressions I took away from it was the importance of better integration of health and social care. And anyone who's been discharged from hospital to go back home knows the importance of that integration. It's just got to run as smoothly as possible. Taking into account the voices of people who use care, and that they're heard so that they can have a good quality of life. And sharing learning with other authorities and stakeholders and organisations. A focus on both paid and unpaid carers. I thought that was really important because, as Max said earlier, quite often it's the care homes that are getting quite a lot of research now at the moment. But the home care, that's perhaps an under-researched area, and yet it's so important to take into account those unpaid carers who in a lot of ways keep the system going. So they're very valuable. And input public contributors can make. Ensuring the micro issues are not lost, I think that's really important, and that's perhaps where I see my input has been really worthwhile. The first wave was about the PPE equipment and quarantine. The second wave about testing and vaccines. And I just wonder what's to come, you know, whether the app will come back into force, because, as you know, it happened in the Isle of Wight, but it was abandoned. So in future times, that might be something that comes back into it. Care homes opening up to visitors, really, really important, because we haven't seen people for so long. And face-to-face contact, now that that's possible, it's opening things up. And yeah, that's it from me.
Sorry, I went a bit too fast there. My fingers slipped. Sorry, Margaret. I hope I didn't rush you.
No, it's all right. Thank you.
I'm very, very grateful, Margaret, for summing up so well the experience of taking part. And I just thought I would share this image of just how confusing our theory of change looked at some points, but amazingly, we managed to gather a huge amount of thoughts and information. And I was showing a bit the process of theory of change earlier. There's a bit of jargon going on, but we had in blue what the stickers of what are the challenges for the system to be able to recover and become more resilient. We had in yellow the outcomes, and these would be the things that need to be into place so that we can move on to the next step as we progress towards the final impact we'd like to achieve, which is that the social care sector recovers and becomes more resilient. Then we had in green the strategies that needed to be put in place for things to happen. And actually in green, there was a bit of mopping up where we were identifying things that we knew from the recording and conversations that were there, but where we didn't have a sticker. So there's quite a lot of work to happen to go from this huge collection of thoughts and ideas and to develop a sequence and a path. And I'm just now going to show you a summarized version of all this information, but just to emphasize, we are including all this information we gathered from the workforce into the thematic analysis for the situational analysis, so none of these thoughts and ideas will be lost. And now I'm going to show you a tidy version. And of course, you can't read it, there's too much, but we will share the slides. And we'll be very, very happy to have feedback on this. We couldn't capture all the nuances of what was said in the workshop, but we did try. And I'm just going to explain the different colors, just to give you an idea of what's happening here. In the darkest color right on the right-hand side, we have the impacts. This is where we'd like to be. And as I said, this changed a bit because of doing the workshop. And the very first one is that so we have the social care sector in England is able to recover from COVID and be resilient in the short term. And then through the workshop, we worked out this required its own different separate path. And this is this bit in the lighter blue color. And then we have a three-part type of impact at the bottom and the darker color, where the social care sector in England is resilient and able to withstand ongoing and future shocks and is well prepared for future infection disease outbreaks. And ultimately, the reason we want this to happen is because the ultimate impact we're hoping to achieve is that people who are supported by long-term care can recover from the impacts of the pandemic, can maintain their autonomy, and are enabled to live independent and fulfilling lives. And the other side of the coin is, of course, an extremely important to happen at the same pandemic and have a good quality of life and well-being and decent work. And this is what was agreed as the impacts through this workshop. Now, in the lighter blue, we have the COVID-specific things that need to happen. And I'm going to summarize because I know you cannot read this, but you will see that there's also some links between what's happening in the pandemic, the actions that are happening as part of the pandemic, and then this central gray section. And now I'm going to show this to you a little bit more. So, and I've put in here, I'm overlaying some yellow stickers that try to summarize a bit what's in all the detail. The first of all is that the sector learns from the evidence and experience of what's happened. And this includes the voices and the experiences of people who use care and of frontline staff. This would ideally lead us to a situation which has a co-developed evidence-informed roadmap out to lead us to recovery and to deal with ongoing COVID. And this is adopted and funded. I think I need to improve a bit the wording in that box. This should ideally position the sector to be able to respond to a changing COVID situation. And the sector would be able to support people who provide care to recover and who use and provide care. A very important link is that we have had, and this came up through the evidence review, some successful innovations that have happened during the pandemic. Some of them are to do with the use of technology, some of it to do with greater working together, more co-development, particularly in the second phase of the pandemic, and also improvements in data gathering and sharing. It's also there is potentially a momentum to learn from the pandemic, and that this leads to increased public and political will for reform. There are, of course, this is a huge issue, and this is very political, and it's on all the newspapers, but there is potentially this situation, and this is something that could emerge as a result of the experience of the pandemic. And this would lead us to a section here in the middle, which is a very brutal summary of what a new national settlement would be that addresses governance, funding, data and coverage, some of the key issues that have emerged as structural problems through the pandemic. A very important part of this would be a workforce strategy. There's much more detail in all the notes and all the smaller stickers, very important that the voice of people who use care and unpaid carers and people who work in the sector are heard and that their rights are upheld. Very important that we have a system that leaves no one behind, including unpaid carers, and that we're able to identify people in a situation of emergency. We've understood the importance of being able to identify the people who may benefit or may need, for example, access to testing because they're providing care at home, or access to PPEs. It's really important to have information systems that include everyone who's providing care. And now, so to go a bit quickly, but we will be sharing the slides. We'll be very happy to have any feedback. But we'd like now to move to a more interactive part of this webinar. And thank you for bearing with us so far. And we have some questions. And what we have discovered is that although Mural and all sorts of additional apps are very good, we found that the chat function in Zoom is very, very good. And having a record of people's thoughts and ideas is wonderful for us to gather information and thoughts and feedback and be able to act on it. So we'd like to invite you to help us answer some of these questions. The first of our, and we've got three. So the first, for those of you in England, actually two questions. We'd like to know if the topics that we've presented and discussed resonate with you. Is there anything that we have missed or that may have been misrepresented? Is there triggering anything that you'd like to share? We'd also like to know what are the key topics where you think we need to learn more? And this is very important to help us gather more views and thoughts about what would be the priority topics for the second phase of our project. So make sure that the topics where we do our scoping reviews or that underline the choice of countries where we want to learn in more detail are relevant to those of you working in the sector in England. Now, some of you have joined from other countries, and in that case, we'd be very keen to hear is there anything that felt striking to you about the experience in England, and what could we learn from your country? And finally, to all of you, we're very interested to hear about other research projects or initiatives that are looking at some of these topics already. We don't want to replicate what others are doing. You have seen this enormous map that has emerged through the theory of change. There's no way our project can address all of the issues and topics that come through. We will be able to answer a very few, but we also want to make sure that we bring together and link with others who are doing work that is relevant and useful. So I'm going to now stop sharing the slide. I'm going to open for discussion. We'd really appreciate if you have any thoughts, you could share your any answers to these questions in the chat. And yeah, please raise your hand if you'd like to speak and share some of these thoughts verbally. I'm also going to share briefly here my email address if you'd like to send your thoughts in writing, or if, for example, you're working on something very similar or relevant, you'd like to send details, please, you can email me. And of course, you can keep an eye on the LTCcovid website and follow the project is also using the LTCcovid account. So thank you very much. And I'm going to stop sharing the screen. And yeah, if anybody would like to share some initial thoughts, discussion, impressions, or ideas on which topics we should be focusing, please let us know. Oh yeah, and delighted to see a first in the chat, something on the social care futures. We'd be very happy to hear you, perhaps because other people may not know what this is. If you want to raise your hand and speak and introduce some of these projects and thoughts, we'd be very appreciative. Donna, would you like to?
Oh, yeah. Yeah.
Thank you.
Hello, Adelina. That's really interesting. Yeah, I come from a charity called Seeability, and we support people with learning disabilities, autism and sight loss. And it's often younger people we support in supported living. And I've been one of the people, I'm sure there's lots of people on this call who have dealt with all the government guidelines coming out daily. And it's been so obvious that the government doesn't really understand where people with learning disabilities live. It's not in often residential care settings as such, it's supported living. So that was sort of one observation. If there's any more sort of work or linking in with the work of Learning Disability England, if you want some contacts there, that would be great, because I know there is a big project on the impact of COVID-19 on people with learning disabilities, and they've interviewed nearly 1,000 people about their experiences, and some of that is picking out on social care. And certainly from a provider point of view, it's been very obvious that PPE, sort of restrictions on visits, all of these things haven't really thought about the lives that younger people lead. And often people have jobs or volunteer, and they're going out to do things, and you know, it's had a massive impact on people. And the other thing is that Social Care Futures, if people, I can put it in the chat, a link to their event on Thursday. That's been going for a couple of years, but they're really trying to change the narrative on social care. And again, if you're one of these people like me that follows a lot of the think tanks that talk about social care, or a lot of the sort of MP reports on social care, always starts off with funding, or starts off with talking about caps on care costs and things like that. It never really starts off talking about what people really want from social care. And they're really trying to change the narrative. And I think they're a really interesting group to listen to and be involved with. And their inquiry has been held by 12 people who use social care, who've held an inquiry and listened to the experiences of 500 other people who use social care. And what they're coming out with is completely different in terms of what reform should look like, as opposed to what some of the sort of, say, the think tanks often say what reform should look like. And actually it doesn't necessarily have to be a lot of money that's needed. It's just a different way of delivering things. So sorry to take up a lot of time, but I just thought there were two interesting things to flag, and I'll put them in the chat box as well.
Ilona, and I really appreciate you've got us started very well here. Just a quick thing to say in relation to learning disabilities England, we are in discussions with them. We are looking to organize an event specifically with them to have our own mini version of a very condensed version of a theory of change discussion with them, or to see what's important. And so it's been excellent, and we're very grateful to also Chris Hatton, who's the project advisory group, for putting us in touch. And we've also been, we had somebody from Social Care Futures in the theory of change, and we hope that we have been able to link quite well with that. We're not trying to cover everything, but I think this type of initiatives are already in place to address. And we hope that this project will also help with understanding how this COVID experience can support some of these other wider activities. And there's some interesting discussion in the chat. I just glimpsed on the language around visiting. And we'd really appreciate suggestions for alternatives, because it's quite common that we want to use a shorthand to say things quickly. And we appreciate that in many cases, people do much more than visiting. when they go to care homes, they're providing all sorts of support, and they're also maintaining personal relationships. And it's any suggestions and alternatives are very welcome. We'd be very happy to hear from others. If you want to raise your hand or unmute to speak, any other thoughts you have, any other initiatives?
Sorry, I couldn't see the sort of formal raise hand function. So thank you everyone for their presentations, which were fantastic, and it's brilliant to see the sort of scope of this work, really exciting. So I could just say something very briefly about the research project that I mentioned in the chat, which I'm involved with. So this is a project funded by the Economic and Social Research Council to analyse the financial impacts of COVID on care homes for older people across the UK. And then the second part of the research is looking at the implications of any financial impacts for people working for those providers at different levels, from from frontline to kind of care home managers and more senior managers. So it sounds like there will be some really great synergies with the work that you're all doing. And very happy to be in touch with anyone who wants to discuss that further. We're partnering with Unison and the National Care Forum on this project. And then I just had a question about the kind of theory of change, and because this is something that I've been thinking about, kind of, you know, how do we make our research as kind of strategic as possible, and just wondered whether you sort of looked at the kind of agents who are involved in those different outcomes, or the kind of opportunities to influence things and achieve change. So I'd love to hear a bit more about that. And sorry, I didn't really introduce myself. So I'm in the geography department at UCL.
Thank you very much, Jamie. And yeah, we will be in touch. And I'd like to follow up with Sue G. Sorry, I'm not sure what the full name is. I think you had some thoughts you wanted to share on, yes, on the language we use. Thank you, Sue.
Thank you. I used to be a carer for my husband who had Parkinson's and vascular dementia. We had a bit of a journey through health and social care, ping-ponging around, with me feeling like I was the kind of glue in it all. And so after my husband died, I stayed on, and I'm involved in a lot of different projects. And although I'm here as an individual, I'm actually involved with the patient liaison group at the BMA at the moment, which is a great privilege. So I just wanted to raise the idea of the partners in care and the devastation that must have caused when those people who were really supporting the care, doing something really active, being company, helping with food, observing potential deteriorations and being able to report it, were denied access. And so I think that's a whole area to discuss. And my other point later in the chat was about caring about, not just caring for. And my example for that would be when my husband was in care, I could go in at any time, and I turned up one Sunday morning and he was in his room with a carer called Paul, and they were doing a crossword. And Paul looked up at me as soon as I went in the room. He said, "Oh, I'm glad you're here because Bob said you would know what 14 down is." And that to me just encapsulated how much they knew about my husband and me and what we like to do. And they'd also moved on with his interest in the care home. And to me, he got all the other stuff, the Parkinson drugs and the help with personal care. But that to me was about caring about my husband and about me. And that really stuck with me, that example. So thank you for listening.
Thank you very much, Sue. That's a great example. And we'll take note of the caring about as well. So I noticed also some suggestions from, I think, from Sarah Daniels on support, enrichment, and advocacy visits, and lots of other things coming on the chat. So, and anybody else would like to share their thoughts, suggestions, you can raise your hand, you can wave. So if you put the camera on, usually then we see you. So just signal if you'd like to speak. And if any members of the team also would like to answer to some of these comments, please don't hold back.
Yeah, there was a comment from Michael Jones about size of care homes and to what extent that was associated with outbreaks and size of outbreaks. As far as I know from the literature that has been looked at I think definitely in some US studies, I'm not sure to what extent that's been looked at in England as well. But I think it's one of those characteristics that are very difficult to disentangle because the size of the care home might also be, so there might be associations with where those care homes are, and we know that community transmission is a big predictor, important predictor. But then also other things like the composition of the care home population might be different in large care homes. The workforce might be different, and so on. So I'm not sure how. So I'm not aware of any sort of clear. I think the evidence is there that there seem to be more cases or more outbreaks in larger care homes. But to what extent that is purely the fact that these are large care homes, or whether there are also other factors that would also be contributing to these care homes being more susceptible to infections being introduced, but then also what's happening inside these care homes once the infection has entered.
Any comments on any topics that you think have been particularly under research? So I was wondering, Sarah, Daniel, so would you like to come in? And I see you have a few interventions in the chat.
Adelina, I was literally just about to push it. I have to go, but I have really enjoyed the meeting, and I've been trying to kind of add some thoughts in the chat around the impact, I suppose, of the digital inclusion and the digital literacy in response to COVID, and how we might continue to move on and capitalize on the advances without losing, you know, the face-to-face contacts that are so important. That people keep talking about the kind of hybrid models, and how do we actually make that a reality for people to continue to benefit from the increased access or potential increased access to support ecosystem, and find some way to complement that with the face-to-face contact. So that was what I was commenting on, but I have to actually go, but thank you very much, and please.
Thank you. Thank you very much. And it is the end of the hour. I know many of you will need to go. Anybody who'd like to stay for a bit longer to keep discussing any topics, any shopping lists you have on things you'd like to know more about, now is the time to influence this project. So feel free to use the opportunity, and thanks for all the records. So I'd like to say, if there's anybody else who'd like to speak, let us know. If not, we can. Oh, yeah. So, and I'm not sure if I'll pronounce this right. Cian Donovan. Hi.
Hi. Thanks, Adelina. It's Cian. Yeah. I'm a researcher at UCL as well, and working on a project about ethics in response. I'll put the details in the list in a minute. Right, look, this is amazing. I'm just, my head's spinning, and particularly the maps you've shown. This is one of the best mappings of kind of policy and reality I've ever seen. This is really, really interesting stuff. Right in the middle of the map, you had a bubble around political will for reform, and so much of what was on the top left to the bottom right seemed to go through that, right? And it's such a tricky issue. But related to that, you had evidence. So I wondered if any of the folks who are doing this research can say anything about maybe the changing evidence base, the different types of local and national data maybe that we've started to see come together or not over the last 18 months, and how maybe this is shaping, or it isn't shaping, that kind of political will, or what we have to do to kind of make progress there. I hope that made sense.
Yeah, and that's not a very easy question to answer, at least now, but it is something that's very clear across any project you will look at, trying to see how change is affected. You have to see how do you have enough political but also public will to support, to generate the will to make the changes. And I think here is where the social care futures work, for example, is very interesting, at looking at how we frame, for example, the idea of care, and how that may have an effect of how people perceive it and their willingness to want to aspire for something better for the present and the future. And I do think that this is actually a really crucial area where I think that we don't have that much research that shows us how do you change perhaps the value that the public put on research. There are some interesting surveys, and I think my colleagues at CPEC have done one, for example, on attitudes towards paying for care. And I think there's other things we could look at internationally. For example, we know that quite a few countries spend more than double as a share of GDP in publicly funded long-term care than we do in England. And it might be that this is also, if our case studies was in one of those countries, this might be one of the questions that we'd like to look at. Is it what makes long-term care an issue that helps you get elected in other countries and maybe not in England. And I do also be very interested to know about others who are studying it. You also mentioned the role of evidence itself in generating this public and political will for change. And I wouldn't be able to make a link here, and I don't know whether there are others who know this area better, but I do think that we now have a lot more information that we had before about how the system worked. There have been lots of ad hoc data collections during the pandemic that have shone a light on some of the gaps that we had in the system. And we're very keen to also hear about how to map all this evidence and understanding we're gathering. And here is where this, what we call a situational analysis in the project, we hope will be able to make a contribution. And there's a question on, so I'm going to jump to the chat on how current research is going to fit into the map. So what I showed you, when I showed the original mural that emerged from the workshop, there were stickers in different colors. What I have shown you in the distilled version was only what we call the outcomes, which is like the stepping stones. But to make those stepping stones happen, we have what in the jargon of theory of change we call the strategies, the actions that you need to take. And of course, evidence research is part of that. So you have the evidence, and then that may or may not be implemented and used. But there is an idea that our research, what we generate through this project, would be some of the actions, at least in terms of evidence, that could help populate. But we are aware that many other people, and that's why we were asking about other projects, are generating and making that evidence available, and will be generating it as we move along. And the idea is that we use this big framework and we populate it. What do we know? What are others already answering? What are the gaps? And then our project will try to make sure that we use the funding that we have for the second phase of the project in the most efficient way to address the important gaps. And when we come to the end of the project, we will do another theory of change. We will revisit where we're at. This will be at the first half of 22. And we're going to see how the knowledge, the research has moved, how maybe the political, there may have been changes, we don't know, we'll see politically in terms of the of being closer to having a new settlement for social care or not. But we will then take stock and see how what we have been learning through our scoping reviews, our learning about the experience of other countries, complements the map. So I hope that answers the question. I don't know which Margaret was it. Was it Margaret Dangor or was it Margaret Ogden?
May I ask a question?
Yes.
My name's Kathleen. Also, I put my video on. For some reason, the hands up function isn't working on my system. Thank you very much for such a stimulating discussion. And I'd like just to touch on resilience, if I may, and please excuse me if I missed some of what you said. Resilience, as you know, I'm stating the obvious, can happen at such an individual level, and it can vary in between inside each of us as individuals. So I just wondered, again, I'm sorry if I'm asking you to repeat something you previously said. Do you anticipate looking at resilience in an institutional way? Care home by care home, even if a sample of it, different groups within the care home sector? I'd be really interested about the resilience. Thank you.
Yeah, so I hope this is not a disappointing answer, but we are going to look at the sector and its ability to deal with shocks, and and it's so it's not going to be, and we don't have the type of infrastructure that a project looking in detail at care, at individual care homes, or even at individuals within the care sector, the people who use care, their own resilience, the resilience of people who work in the sector. This will be quite a different type of project, and but definitely a very important one to address as well. So we will be looking at a macro level, I'd say, and the preparedness for shocks and for and for being able to respond to crisis.
Yes, and again, may I ask another question? Are there well-known measurements of that sector readiness, that sector capacity, or are you hoping to perhaps propose some measures?
So we do have a question about how do we know, what would be the indicators, and we asked that at the theory of change, and we haven't yet got to analyzing all the answers of how we asked the participants how they thought we could be measuring whether we had achieved some of these steps towards greater resilience in the sector. There are, as far as we know, there aren't frameworks doing that yet for specific to social care, but there are some frameworks on preparedness for pandemics that, for example, could be adapted. And we think that the theory of change, this map that we have done, can also make a contribution towards understanding how that could apply and be adapted to the social care sector in England. So watch this space, but this would be, as I said, at the macro sector level rather than providers.
Thank you very much.
Thank you. And I see two hands, and I'm going to invite first Martin Knapp.
My comment is actually a bit cheeky to Kathleen, really, because Kathleen, I know you're going to start a new research project soon. I don't know whether you're happy to tell people about it, because it's quite relevant to the webinar. Sorry to put you on the spot.
Hello, Martin. No, that's perfectly all right. Thank you for the opportunity. Next month, our team, we're based at the University of East Anglia, which is in Norwich. Our team is going to start looking at the lived experience of infection risk and transmission in care homes for older people. It's going to be mixed methods. So we're going to do an online survey of staff, and then the qualitative component is larger, and we're intending to interview care home residents, family or friends, and staff. And there does not have to be a dyadic or triadic relationship amongst those three different groups of people. And our intention is to learn not just about COVID, which of course is important, because aspects of preparedness will come into this in terms of infection transmission, but also what can we learn for future infectious disease outbreaks in care homes.
Thank you, and thank you, Martin, for making sure we got the extra information. This will definitely be a project for us to watch. And as I said, this is a huge map we have put out there, and there'll be many contributions by many teams that we just want to know what they're
and
doing.
how.
So exactly.
Yes.
So
in fact, sometimes I wonder, in addition to the wonderful database that LTCcovid, you're trying to encourage people, to perhaps, whether you say advertise or make known, because that can be a challenge, can't it, in whatever work we're doing, just to find out what's going on out there.
Yes, and we will be restarting again a more regular series of webinars, and we will be going through the database of projects that we have, but also others we're finding out about through events like today, to invite people to help us complete the picture and to also update and share. Because there's plenty to do this year.
Yes, so I completely subscribe to that. Thank you.
Thank you. There's another hand up, Margaret Dangor.
Yes,
hi, Margaret.
I just wanted to, thinking again of unpaid carers, Sue G, who looked after her husband with Parkinson's, mentioned the term we use, partners in care, for unpaid carers. And to me, this is so important as a past carer and working with carers. And I'm looking at that term, which we try and use in the UK, but it made me think about how do other countries approach unpaid carers and their attitude to unpaid carers and how they bring them into the organisation of care and the management of individual care. I mean, I'm on the team, but it just it's really important, the terminology we use, and it changes the whole approach, if you like, to how you look upon the care of people, that it's not only in the residential environments, but also, you know, they might be in a residential environment, but the family matter, of course, very much to them. And we shouldn't forget them at any time. And we certainly did neglect that part of the care planning and the care management during COVID particularly.
Thank you, Margaret. That's very well noted. And yeah, we're very lucky to have you in the team as well. I would like to invite also Rosie Reed. I understand you have a very relevant project, and thanks for sharing in the chat.
Hi there. Yeah, well, thanks for the invitation to speak or to introduce it briefly. My name is Rosie Reed. I'm based at Bournemouth University on the south coast of England. I'm a social anthropologist by background, but I'm doing a study which is, you know, at a smaller scale to this and much more regional, I guess. But it's looking at care given and received in the context of home, at home, during COVID. And I want to look at it from the point of view, I am looking at it from the point of view of different people involved in care. So waged care workers who are providing domiciliary care at home, volunteers who responded to various kind of initiatives in this area, particularly local government initiatives to support shielders, carers, obviously a really important group, and people who receive any of these forms of care or support. And I'm looking at that both in Bournemouth, in the sort of urban conurbation where I live, as well as the neighbouring county of Dorset. I'm in the process of gathering data now. It's a qualitative study, so it's mainly doing interviews over Zoom and having kind of smaller meetings also over Zoom or Teams or whatever people can do. There's a lot that I'm finding that really resonates with the really interesting work you presented today. So I'm very glad I came and hope we can stay in touch.
Thank you, and we'll be very keen to hear how your project develops and any outcomes. And we will try and contact all of you who've told us about projects. We will be reviewing the chat, and I hope it's okay to get in touch. I understand, so I'm just going to actually go for some people specifically, and I'm going to ask Klara Lorenz-Dant. Klara, do you be happy to tell a bit about the project on visiting you're working at the moment?
Can I just say, Rosie, that sounds very interesting. Very interesting. I'd be very interested in hearing more about your work. I know that area quite well, but it'd be really fascinating to see those different aspects that you're planning on investigating. So we have another study which is called the Visited study, and I can't see Josie Dixon, who's the PI on the project. If she's here, then please interrupt me. But basically, we're looking at that kind of critical term of visiting policies and actually what has happened during the pandemic. And we're looking at it from a policy perspective, which is why we're very much focusing on that. And what we're doing in two parts is a qualitative survey with care home managers or nominated staff, trying to understand of how care homes have experienced the pandemic and sort of the policies that came out often at quite quick succession, and what that meant for different care homes in terms of developing their own policies, communicating with families and residents, and sort of all those different components. We are also conducting some qualitative interviews to follow up on the kind of key findings from the survey with care home managers and nominated staff. But also we'll be doing qualitative interviews with relatives of people living in care homes, so care partners, unpaid carers, whatever the term you would like to choose, but really looking at those different components. And again, looking at it from a policy perspective and sort of thinking about how have people been involved in, have they been consulted in what's been going on, how have they been informed about certain things, how have all of these processes happened throughout the pandemic, and how sort of what perhaps has also been already the learning from early on in the pandemic to where we are now. So in a nutshell, if there's a sort of brief summary on the LTCcovid website, but that's another study.
Thank you very much, Klara. And I'd like to invite Donald. I'm not going to attempt to pronounce your surname, sorry. But I think you had some interesting perspectives from Canada. Thank you very much.
Don Jesuitian, just like it's spelled. And we have, because of the vast size of the country and the federal structure really establishes a fair amount of complexity in respect to the way the COVID responses took place across Canada. So each of the provincial jurisdictions and territories have responsibility for the long-term care provision within the communities. And so there was huge variation in the country. And so there have been several initiatives that have been undertaken to try and understand what some of the best practices might have been emerging from the response to the pandemic in the residential settings and home care settings. The country actually, in comparison to the OECD peers, does extremely poorly in respect to provision of services to home care. So many of ours were in residential settings, and in the provinces of Quebec and Ontario, we had some of the highest incidents of negative consequences. So we had something in the order of 17,000, well over 20,000 deaths now of individuals within residential care facilities. So there is one project that you can look at, which is called Age Well, being run out of Toronto and Simon Fraser University, in which there is a strong effort to try and collate some of the best practices like you're trying to identify with your initiative. It isn't quite as broadly situated, but I'd be happy to provide links to that. And our seniors advocate in the province of British Columbia, and she is only one of 2 seniors advocates in the country, one in New Brunswick and one here in British Columbia, have been a bit of a focal point in providing a public policy orientation to how do we respond to this in order to mobilize political will to actually take some serious efforts to prevent future problems from arising in the event of a shock event such as the pandemic. So there are activities, some of them are focused, and I think we could learn a lot from linking in with your work and collaborating in that fashion.
Thank you very much. I would be very interested to learn from these experiences, and it's okay, I'll try and follow up. Thank you. And I'd just like to check, Nathan Jones, would you like to comment? Jones?
Yes, yeah. Yes, thank you, Adelina, and thank you to everyone who's worked on this project. It's just been amazing seeing everything that's gone into that mapping, and it'll be very useful for our policy work as well. So I'm from the National Care Forum, and we represent not-for-profit social care providers in the UK, but mainly thinking about policy in England. And I just want to add a bit to the conversation we just had on visiting, and we actually learned quite a lot from what was going on in Canada, and particularly in Ontario. And we worked with, I think it would have been back in November now. We worked with the Ontario Long-Term Care Association and to understand what their approach had been to visiting. And I think last summer, the Ontario Legislative Assembly actually passed a law which made essential caregivers, essentially give them the right in legislation to be able to enter care homes and other institutional settings to actually provide that care that they would have done previous to the pandemic. And we were able to use sort of our work with that Long-Term Care Association to essentially lobby the Department of Health and Social Care to introduce something similar into the visiting guidance that we have in the UK. I think we can agree, from our perspective, there's been massive human rights issues the entire way through for people living in these settings. So, whether we need some sort of Bill of Rights or something similar here, or something that just really does allow unpaid carers and those that know their family members and friends best to be able to come into those settings. So just wanted to say that the sort of international comparative work is incredibly useful for policy work and is very influential.
Thank you very much. That's much appreciated, and I hope that this project will help to condense and crystallize some of this learning as well. It has really been amazing how much people have mobilized to share what was happening in their countries. We've done it all very rapidly, and I think that especially when we have these longer term reforms and trends to put in place, to be able to do that in a more systematic way. So I think we're almost at the end of the time we had. We may have one last comment if anybody has been waiting, but unless I hear any other hand or see anybody unmutes and speaks, I think we probably just want to thank you, and thanks for everything you are sharing in the chat box. We're going to come through it, and we may be in touch with some of you and try to find out more about your projects. We will be doing some webinars to understand more about ongoing work and initial findings, to make sure, as I said, that we can choose the topics that we're going to be focused on in a way that they don't repeat what somebody else is doing, but hopefully create synchronism between us. We can fill in this vast map that we have developed in terms of all the actions, evidence, and outcomes that we hope to see in the future. So thank you very much, and enjoy the rest of your day. We will share the slides through the LTCcovid website, and have a good rest of your day. Thanks. Bye.